Hi, we are going to talk about the left atrium. Description, function, and pathology. Definition and description. The left atrium is one of four chambers in the human heart. It receives oxygenated blood from the pulmonary veins and pumps it into the left ventricle via the mitral valve. Atria facilitate circulation primarily by allowing uninterrupted venous flow to the heart, preventing the inertia of interrupted venous flow that would otherwise occur at each ventricle systole. There is a foramen ovale or oval hole between the right and left atrium in the fetus. After birth, this should close. If it does not, this is a natural septal defect, hole in the heart. In the fetus, the right atrium pumps blood into the left atrium, bypassing the pulmonary circulation, which is useless in the fetus. In an adult, a septal defect will result in flow in the reverse direction from the left atrium to the right, which will reduce cardiac output, potentially cause cardiac failure, and in severe or untreated cases, death. The left atrium is supplied mainly by the left circumflex coronary artery, though the branches are too small to be identified in a cadaveric human heart and are not named. The oblique vein of the left atrium is partly responsible of the venous drainage. It derives from the embryonic left superior vena cava. Function. The left atrium has 5 main functions. The best known function is that of a blood receiving reservoir chamber. Second, it also is a contractile chamber that, by presystolic contraction and its atrial booster function, helps complete the left ventricle filling. Third, it functions as a conduit that empties its contents into the left ventricle down a pressure gradient after the mitral valve opens. Fourth, it is the volume sensor of the heart, releasing atrial natriuretic peptide in response to intermittent stretch so that an ANP-induced diuresis can help restore blood volume to normal. Fifth and finally, the atrium contains receptors for the afferent arms of various reflexes, including mechanoreceptors that increase sinus discharge rate, thereby contributing to the tachycardia of exercise as the venous return increases. This is known as the Bainbridge reflex. The atrial pressure volume loop is very different in shape from that of the ventricles, resembling a figure of 8. During atrial pacing, the preload is increased and the atria are distended, so that the volume part of the loop is small and the pressure part of the loop is much enlarged. The atria have a number of differences in structure and function from the ventricles, including smaller myocytes, a shorter action potential duration, and a more fetal type of myosin, both in heavy and light chains. The more rapid atrial repolarization is thought to be due to increased outward potassium currents. In general, these histologic and physiologic changes can be related to the decreased need for the atria to generate high intrachamber pressures, rather being sensitive to volume changes, while retaining enough contractile action to help with left ventricle filling and to respond to inotropic stimuli. The cellular mechanisms include decreased L-type calcium channel activity, increased abnormal collagen, and probably adverse stretch-induced signaling. The results include poor contractile performance and an increased initiation and perpetuation of atrial fibrillation. Left atrial myxoma. Left atrial myxoma is usually a solid, round, or polypoid mass without a cystic structure attached to the interatrial septum. The size of the mass ranges from 1 to 15 centimeters and is usually about 5 to 6 centimeters. The mass has solid content with a consistency varying according to the amount of collagen it contains. The preoperative diagnosis of a cardiac mass has been enabled by echocardiographic examination. Atrial fibrillation. According to the multiple wavelet hypothesis, atrial fibrillation is characterized by fragmentation of the wavefront into multiple daughter wavelets. These wander randomly throughout the atrium and give rise to new wavelets that collide with each other and are mutually annihilated, or that give rise to new wavelets in a perpetual activity.
Okay, so this is a tutorial on the left side of the heart. So it's following on from the tutorials I did on the right atrium and right ventricle. And there's a bit of overlap in terms of the structures in the left and right sides of the heart. So I'm not going to go over them in massive details again, so you can refer to those tutorials to clear things up a little bit more. So we'll start with the left atrium and then work into the left ventricle. So the left atrium, externally you can see this appendage here. So just like on the right side you've got this right atrial appendage or auricle, you've got the same on the left side. So you've got this left atrial appendage. And then if I rotate the model around posteriorly, you can see these 4 veins entering into the left atrium. And these are the pulmonary veins, and they carry oxygenated blood from the lungs back into the left side of the heart. So the function of the left side of the heart is to pump blood out to the rest of the body, oxygenated blood to the rest of the body. So I'll just rotate the model back round again and we'll talk about some of the internal features of the left atrium. So similar to the right atrium, the left atrium has 2 divisions. So it's a little bit smaller than the right atrium, but it's actually thicker, the walls are thicker. So the posterior division of the left atrium, just like the right atrium, has smooth walls, and this aspect of the right atrium, this posterior aspect, receives these 4 pulmonary veins. So the anterior half is continuous with this auricle, this left auricle here, and this half of the left atrium contains the rough ridges, so it's got the musculi pectinati. But unlike the right atrium, there's no crista terminalis. So you've got the smooth posterior surface of the left atrium and the rough, muscle-ridged anterior surface, or anterior half, which is continuous with the left auricle. But unlike the right atrium, where you have this smooth muscular ridge delineating the 2 halves, which is called the crista terminalis, you don't have this in the left atrium. So I've just sliced the heart in half, and we'll take a look at the wall of the atrium. So the wall dividing the right from the left atrium is known as the interatrial septum. And remember I showed you the oval depression in the right atrium. You've also got this oval depression on the left side, because remember it's a remnant of the foramen ovale, which is a hole in the interatrial septum which allows blood to flow from the right to the left side of the heart, bypassing the lungs, which are not functional at birth. So those are a few things to know about the left atrium.
Oxygenated blood returning from the right and the left lungs is collected by the pulmonary veins, and the pulmonary veins will then drain this oxygenated blood into the left atrium, which you see right over here. We have removed the wall of the left atrium so that you can see the interior of this chamber. And here you can see the opening that allows blood to flow into the left ventricle. So this is the orifice, the left atrioventricular orifice, and it's going to have a valve, the left AV valve, the mitral valve, that's going to prevent blood from flowing back into the left atrium. Over here, notice that here's the other side of the fossa ovalis, and so this represents the interatrial septum. So the interatrial septum, the wall between the right and the left atria, is located right over here.
Atrial fibrillation is a rapid and disorganized electrical disturbance of the heart. In distinction to the normal rhythm, which begins in the SA node, or the biological pacemaker of the heart, and leads to 1 beat of the collecting chambers for every beat of the pumping chambers, atrial fibrillation is quite different. When atrial fibrillation starts, it starts with an extra beat, often occurring in the left collecting chamber called the left atrium, which, if you like, displaces or takes over from the function of the normal biological pacemaker. This extra beat then leads to a rapid, disorganized set of multiple short circuits, which are set up in the collecting chambers. As a consequence now, the electrical function of the collecting chambers during atrial fibrillation is taken over, if you like, from the normal biological pacemaker, which then disappears. It no longer has any function during atrial fibrillation. What happens to the collecting chambers when you have these multiple short circuits in the collecting chambers is that they quiver. They beat very rapidly and uncontrollably, as many as 400 to 500 times a minute. So atrial fibrillation means that the atria, or collecting chambers, are quivering or beating very rapidly, so-called fibrillation. Now, most patients don't actually feel the atrial fibrillation itself, because all of us don't feel how our collecting chambers are functioning. What we feel is the rapid and irregular beating of the pumping chambers. So how are the collecting and the pumping chambers connected? Well, they're connected in the same way as in a normal heart rhythm, except that in atrial fibrillation there are now 400 or 500 of these electrical impulses every minute that come into the top of the funnel known as the AV node. Now, fortunately, not that many of these impulses exit the bottom of the funnel. Our pumping chambers couldn't beat 400 or 500 times a minute. They can't beat that fast. And so the AV node filters out most of these 400 or 500 impulses per minute, but allows to pass through maybe 100, 150 impulses per minute. So the result of atrial fibrillation, which is the very rapid quivering from multiple short circuits of the collecting chamber, is the somewhat rapid but still steady beating of the pumping chambers at somewhere between 100 to 150 beats a minute. And what patients feel during atrial fibrillation is this sensation of rapid or irregular heartbeat, sometimes accompanied by dizziness or lightheadedness or shortness of breath.